Hello and welcome. I'm Dr. Lewis Hassel, Professor of Pathology at the University of Oklahoma, and I'm glad to welcome you to my program, Digital Pathology Review and Sign Out. Today's case comes from the realm of hepatic pathology and involves a presentation that we sometimes see in this setting where we just have sort of chemical evidence of an abnormality. So the woman is a 43-year-old who has had some elevated liver enzymes detected on a recent evaluation. Um, the lab values look sort of like this, and I've here, rather than using actual numbers, I've just provided ratios to the normal median. So her AST and ALT were both elevated at either 1.5 to 2 times normal. But other liver functions were relatively normal. Gamma GT and albumin were within normal range. Billy was marginally increased. So, a first part of the workup was an evaluation for serology to exclude potentially infectious hepatitis, and her antibody evaluations for A, B, and C were all negative. However, she was noted to have elevated anti-SM antibodies. Her antimicrosomal antibody evaluation was negative. So, given that presentation, the clinical suspicion was pretty high that she may have an autoimmune type of hepatitis. Reviewing her history, however, did not demonstrate any evidence of other forms of autoimmune disease in the thyroid, salivary glands, pancreas, or elsewhere. So we'll go and take a look at what her slides look like after they performed this liver biopsy. You can see here we have two cores with an area of portal tissue here and here, and a little bit of sort of a bluish blush to this tissue. Now, if you'll forgive the dirt on the slide and a little bit of folding to the tissue, I think you'll see that there is a bit of inflammatory tissue here in the uh, portal tract areas. Here we can see a bile duct there. And there also appears to be an increase in uh, pink tissue with maybe some sort of nodularity here and fibrosis between areas of potential hepatocytes. Additionally, the hepatocytes have this sort of vacuolar clearing to the cytoplasm in some areas. As we look a little bit further, we see that there may be a few eosinophils in the portal triads. But this inflammatory infiltrate involves some of the lobules, as you can see here, out into the lobular parenchyma, and is present uh, in the portal tracts there, a small one with some active inflammation going on. As we look at this a little bit further, uh, we'll focus here on the type of inflammation that we're seeing. So you can see there's a number of sort of intraepithelial or intrahepatic cells with extra nuclei, so to speak, with this bit of clearing around them, suggesting that this is an intraepithelial lymphoid inflammatory process. Additionally, we see some cells like this one here, where there may be a degree of apoptosis or uh, death of the hepatocytes in some areas. So there's clearly a damage to the hepatocytes. We have some resulting fibrosis, as you see here, a predominantly lymphoid infiltrate, although I think you'll see that there are also some plasma cells, and I took a few higher magnification views, which I'll show in just a minute. But just to emphasize that to make the diagnosis of autoimmune hepatitis, we don't just rely on histology, nor do we just rely on the clinical laboratory findings, but these fit together to form a picture that is convincing and consistent with an autoimmune etiology. This is more common in female patients and may be associated with other types of autoimmune disease. Typically, you do have anti-smooth muscle antibody, anti-SM, and the histologic features are those of an interface hepatitis with some lymphocytes or lymphoplasmacytic infiltrate. And this intraepithelial lymphocytosis is called emperipolesis. Some people have described rosetting, although that's not felt to be a highly consistent feature. So here's a higher magnification view to illustrate the imperipolesis, as you see, some intrahepatocyte lymphoid nuclei. And here in this one, you may also get a degree of rosetting with a little bit of a suggestion of a central lumina to that cell there. Here we have, again, a little bit of hepatocyte damage. And you'll see also, again, the lymphoid character, the extra lymphoid nuclei invading the hepatocyte spaces. So if we look at how these patients present, I just took this very quickly from Path Outlines. Many patients will be asymptomatic. And most patients have very nonspecific symptoms: fatigue, anorexia, weight loss, maybe a little jaundice, pruritus if they're jaundiced, and they may also have amenorrhea. Um, However, some patients, again, about a third perhaps, may have acute or fulminant hepatitis with almost a liver failure type of appearance. Up to 40% can have extrahepatic autoimmune disorders, which we've alluded to earlier. And in fact, and unfortunately, this is a cause of cryptogenic cirrhosis because many patients will have cirrhosis already present at the time of presentation. In fact, in North America, this is one of the most frequent causes of cryptogenic cirrhosis. Um, in terms of future cancer risk, these patients do have an elevated risk of hepatocellular carcinoma as compared to other patients without autoimmune hepatitis. In terms of the differential diagnosis, we certainly want to consider the hepatitis C most commonly, but hepatitis A, which can in an early phase resemble autoimmune hepatitis. Drug or toxin reactions can certainly also occur in this situation, and so evaluating the drug history is important. And finally, there are various biliary disorders, primary biliary cholangitis and sclerosing cholangitis, which can account for the kinds of chemical and histologic findings that we see. However, these latter two tend to be focused on the biliary tree, and damage to that biliary tree would be a prominent feature, whereas in autoimmune hepatitis, that is usually not the case. I've included here a couple of additional digital slide examples from our teaching files to just allow you to further review those findings. Here again, we see some of the vacuolar change of the hepatocytes. Here, a forceps mark in the tissue. But then again, notice here this mixed inflammatory infiltrate, some plasma cells, lymphocytes, and extension out here along the interface into the hepatic lobule. And then here, another example, a little bit less prominent cirrhosis in this case, although there may be some which would become evident with a collagen-focused stain such as the trichrome. But again, a dense inflammatory infiltrate with extension into the lobules, as you see here, blurring this border between the hepatic lobule and either the central vein or portal tracts. So our final sign-out diagnosis today is autoimmune hepatitis, which in this case is associated with cirrhosis. I didn't show you the trichrome stain, but it was fairly convincing. And a 43-year-old woman, this may progress to the point where she may be a candidate for transplant if her cirrhosis is progressive. However, if we can control it and help her to get a few more years of good life out of her liver, that would be certainly a good outcome. Well, thanks so much for joining me for this session. I hope that it helps you a little bit and that you'll hit that like button and also subscribe. We welcome you to be in our group of subscribers so that you'll catch future releases of new videos as we put them out. They come from a variety of venues and variety of types, and we're getting a diverse array of cases to consider. So once again, Thanks so much for joining me.